Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. I'm excited to host Sam King today on the podcast. She's a physical therapist with MedStar Health. She's our program specialist for Return to Play. Sam attended Bloomsburg University, where she received her bachelor's degree in exercise science. She also attended the University of the Sciences in Philadelphia, where she completed her doctoral degree in PT. Sam has spent time working with the athletes at Morgan State University, Go Bears, and now currently works at our South Baltimore clinic. I'm excited to hop on this call with Sam to talk about copers, non-copers, and adapters as it relates to ACL rehab. We have Sam King here today. Thank you for joining us. Excited to have you.
I am very happy to be here. I'm excited.
Sweet. Okay. I want to start with just getting a little bit about you, your PT history, why you became a PT, and kind of what practice looks like.
So I have been a PT for about 7 years now. I went to Bloomsburg University in Pennsylvania, played lacrosse for 4 years there, and then went to University of the Sciences in Philly for PT school. I ultimately decided that I wanted to be a PT because I had to do shadowing hours for my exercise science degree. I spent some time in the training room and then went and shadowed at a PT clinic. And the idea of being able to help people through exercise just like really drives me. And I think that exercise has always been just such a huge part of my life that to use that for healing is just amazing. I started my PT career, I guess, at an outpatient clinic in Bel Air, and I was there for about 1.5 years, and then came to MedStar 5 years ago. I spent a little bit of time in Morgan State University's training room as well, but now I practice primarily out of South Baltimore and recently took on the role as our Return to Play program specialist at MedStar. It's been a long time.
Awesome. Today we're talking about copers versus non-copers versus adapters regarding ACL surgery. And I'd like to just begin with what do those terms even mean? What is a coper? What's a non-coper? What's an adapter?
Okay, so I want to take a step back and just tell you why this has been such a huge topic for me. I've recently seen a lot of patients that come to me and they're of a certain patient population that comes in after ACL surgery and doesn't come in overly active, or their goals are just very realistic. They want to be able to walk around the grocery store and play with their kids and no cutting, pivoting, twisting, nothing, no crazy sports like that. And some of them have just been really struggling through this rehab. And it got me looking into a little bit more of how essential or beneficial is an ACL reconstruction versus maybe somebody that can live their daily life without surgery. So that brings us to the topic of copers, non-copers, and adapters. And a coper is essentially any person or athlete who is able to resume their prior level of activity after an ACL tear, including pivoting sports, without any periods of instability for at least 1 year. So that population of people that tears their ACL, but they're still able to do everything that they were doing prior to without those reports of oh, my knee buckled, or it felt like it was giving out, or I fell. And then you have the non-copers, which is the classification of people that just tear their ACLs and are constantly having these periods of dynamic instability, despite having gone through PT, despite having done the whole gamut of rehab and rest and all that. And then you have your adapters, who are the classification of people that are able to go without an ACL reconstruction, but they make modifications to their lives that don't include the pivoting sports. So that would be maybe your athlete that comes in after an ACL tear and decides, I just want to do I just want to run. I just want to live my life, but I don't really need to play soccer anymore. I don't need to play touch football anymore. And it's those people that they don't have surgery, but they're also not returning to their prior level of function. Those are the three general categories.
Yeah, I think I like the kind of more intro you gave because I too have seen a handful of people who had torn their ACL, and again they're not trying to get back to any crazy sports, and it's a grueling surgery. I think a lot of people
Mhm.
go into it not realizing how long of a process it is, and when you have that conversation, like this is a 9 to 12 month recovery, sometimes longer. That can definitely deter someone from going through with it.
And then we get these people to put them into the COBRA classification. They have to do rehab first, and that does give us the opportunity, whether they fall into the COPR, non-COPR, or adapter category, gives us that time to educate the patients that, hey, if you do have surgery, it's going to be a 9 to 12 month recovery. You're dealing with an increased risk of some degeneration, pain, swelling for a year or multiple years after your surgery. So um, they say that the classifications are fluid. Like just because you're labeled a COPR initially doesn't mean that you're going to be a COPR forever. It could mean that you end up having surgery down the line, but it at least gives us the opportunity as therapists to educate the patient like, listen, we may be able to get you through this without surgery, but here's what surgery would entail should we go through with it.
I had an athlete a couple years ago who had a partial tear and tried to return back to sport, never really got her extension back, and ultimately tore it completely later on, had the surgery, and had those range of motion deficits that were a bear to work through in rehab. So it's complicated. It's not so straightforward as like I tear my ACL, I'm good to go, like have surgery.
Exactly. And I mean, I have a couple of patients, I don't mean to generalize in any way, but like middle-aged, mid-40s, maybe early 50s women that toured skiing, but skiing's not their livelihood. And then we deal with the range of motion deficits, the swelling, the lack of motivation to get through your 9 months. And then we want to go through with like return to play testing or return to function testing. And like these people don't want to hop and skip and jump and all that. So that's kind of the population I've been working with now, where I've been thinking more like, could we have maybe coped prior to this whole 9 to 12 months of rehab?
I think another piece of the conversation that we need to have is that, or to think about, when kids are in high school, college, like sport is their career, it's their job, it's their primary focus. But when you're getting into your 30s, 40s, you have other responsibilities and jobs, and you can't dedicate every hour to the day of your recovery. So that might sway someone to have a surgery or not have a surgery, depending on if they have the ability to be a coper or an adapter, right?
Exactly. And I mean, I just came off of an ankle fracture and know that, like, if this were to happen again, I can't live my life for another 6, 8, 10 weeks on crutches or a knee scooter. So I think it's really important that we educate patients after an ACL tear, whether they're coping or non coping, just kind of what the rehab after surgery is going to entail, just in case maybe this is not the best time in their life to have it, but there could be 6 months from now that if we, or a year that we could get them through coping until it's a better time to have surgery.
Say we determine that someone is a coper. What is the perturbation training program?
So the perturbation training, it's research out of the University of Delaware, and it is a 10 session rehab program. And it involves progressive perturbations or like reactive training. And it is like a progression of unstable surfaces as well as the therapist providing pressure or perturbations, pushes, dynamic instability on a rocker board, a roller board, and on, yeah, rocker board and roller board, but progressing from double stance to single leg stance, adding a ball, adding, any unpredictable environment. So we'll put somebody on maybe the wobble board and have them throw a ball up against a trampoline, or have the therapist throw stuff at them or kind of knock the board around a bit. And you want to start adding sport specific tasks to it as you get closer to that 8, 9, 10 rehab session. So maybe giving your lacrosse player a stick to help to do single leg stance while catching and throwing. And the basic idea behind it is that we're trying to develop that dynamic stability in their ACL deficient knee, so that they don't necessarily notice, or the body isn't reacting necessarily to the lack of an ACL because the muscles are kind of taking over and providing that stability. I think that should sum up the perturbation program. You also want to include, strength training and kind of the neuro re-ed side of things. So recently we've been doing, I'll start the patient with the balance training or the perturbation training. I'll put them on the roller board, the rocker board, and do my perturbations, and then progress through your quad strengthening, your hip strengthening, calf strengthening, and then move through some core at the end.
It's pretty similar to what a post-op ACL rehab would be anyway.
Yes.
Yeah.
And I've actually been doing it with there's a chart of things which we can always link to the podcast, and it just goes through exactly what you're supposed to be doing. So with the rocker board, or the wobble board as we call it, you do single leg, anterior, posterior, medial, lateral, and then double leg, anterior, posterior, medial, lateral, and go through all that. But I've actually been doing it a lot more with my ACL patients as well, with both legs, just to, promote good knee health and promote that dynamic stability to prevent injury, hopefully going forward, or reduce the risk.
We know when patients tear their ACL that those proprioceptors get disrupted. So that's a key purpose of why this training is so important to, as you were saying, kind of train the muscles to be that dynamic stabilizer, because the ligamentous stabilizers aren't doing their job in that position. It makes a lot of sense.
And I can tell you, I know as therapists, we sometimes like ebb and flow in what we include with our training programs. And this has been something I've known about, the perturbation training protocol, but when the clinic's busy or patients can just do balance on their own, sometimes it, falls to the wayside. But I've been integrating this a lot more, and people are challenged by it. They're excited by it. And it gives you kind of a good flow of where to start and how to progress through perturbations with everyone, I think.
Is this
So,
stuff that you give them to work on at home as well, or is this more guided by the PT?
a little bit of both. Obviously, I don't tell everyone to go home and stand on a wobble board or rocker board on their own. But I will suggest that they go home and maybe practice their single leg stance or their tandem stance and add in some head turns, left, right, up and down, or practice with their eyes closed, just to kind of keep everything going. And with your super competitive people, they don't like to be bad at things. They don't like they don't like failure. So more often than not, I have several patients that have purchased AirX pads, that have purchased wobble boards, that have their kids or their husbands throwing balls at them while they're standing on one leg. And it's really neat to see that the progression and the improvements that they make over the course of, the 10 sessions.
As far as returning to play, so we know that copers can get back to some higher level of activity. How do you, what kind of criteria? Is it similar to normal return to play? Are there modifications? How does that look?
So ultimately, we still follow kind of the return to play criteria that we would for post-op ACL reconstruction. But for the copers, you're really looking at 3 months for return to running or cycling or swimming or anything that doesn't require the cutting, pivoting, and twisting. And you're still looking for that 6 to 9 months for return to any sport that involves those movements, such as like soccer or volleyball, football, that kind of stuff. So timeline, I think, is very similar to after an ACL reconstruction. But for our copers, we still would run them through our typical return to play testing. So they would do their strength testing, looking for their ACL deficient knee to have at least with 90% strength. We do quads and hamstrings. In our clinic, we do the leg press, but that could be also like biodex testing. It could be a handheld dynamometer, anything that you can to test strength. And then we do the LESS testing, which is the landing error scoring system, which for those not familiar, patients jumping off of like a 12-inch box, rebounding and landing again. And we score through that system, picking out different landing mechanics or body mechanics that may indicate an increased risk for injury. Scoring on that needs to be less than a 4. And then we would look at the 4 hop tests that are very familiar to those that do ACL return to play, but the single leg hop, the triple hop, crossover hop, and then the 6-meter timed test. And you want all of those values for your ACL deficient knee to be within 90% of your good knee. And then we'll look at subjective measures like the KOS, the ADLs, and the sport specific, as well as a global rating scale, just to make sure that confidence and actual objective measures kind of fall within each other. But I think the important thing is like not necessarily looking at that 3-month or the 6 to 9-month kind of timeline. I more and more have become a firm believer that we need to do criterion-based progressions instead of time-based progressions. So it's been the age-old tale that like after an ACL reconstruction, you can start running at 12 weeks. But if you start running at 12 weeks and you only have 50% quad strength, surgical leg, non-surgical leg, or ACL deficient knee versus your normal knee, you're not doing the athlete any justice or the patient any justice. So I really think that, taking a step back as clinicians and looking at what do their body mechanics look like when they're running? What does their hopping look like? Are they safe to get on a treadmill right now? Do we think that they're safe enough to do a triple hop or to jump off a box, and not just looking at that, oh, it's been 6 months, it's time to start playing soccer again. I think it really needs to be like, and especially for these copers who we know have like they're ACL deficient, I think we almost need to be pickier for them on their return to play criteria instead of just saying like, oh, 9 months. Literature says we could probably go back by now, but not every person is created equal. And I think that we really need to like be sure that these people are ready to return to sport.
I appreciate those thoughts tremendously because I always tell people the ACL surgery is pretty easy to treat, but it's the human behind it that brings all the other factors to it that makes the rehab interesting. And it's that rehab can't be cookie cutter for these athletes and patients. So
Exactly.
Great points.
I get the athlete that comes in like, am I behind? Am I behind? And well, have you been doing your exercises at home? How frequently are you coming to PT? Is your diet right? Is your mental health right? Are you resting enough? Like there are a lot of other factors other than, oh, you're 16 weeks post-op that would tell me whether you're behind or not. So I have definitely in the past couple of years probably changed the way that I treat a lot more. You come out of school and all you know is timelines and all you know is what protocols say and all you know is what your instructors have told you. But I like most of my ACL reconstructions, I do a gait analysis on them as soon as they start running just to make sure that like, have I addressed their glute med strength enough that they're not having hip drop, or what do their landing mechanics look like? Are their quads strong enough to tolerate this? Is their cadence okay? Like looking at all of these little pieces of the puzzle just to make sure that we're building the strongest athletes that we can and clearing people when to do these fun activities when it's the appropriate time to do so.
Yeah, definitely agree. As far as getting patients who want to try to be a coper, often we get patients, they're post-op. We don't see everyone prehab. So how are we trying to get these patients in before surgery to see if this is an option? Is that a conversation that you're having with the doctor or the patient's having with the doctor? How does that work?
So we're very lucky at South Baltimore that we have 2 very good surgeons across the hall doing ACL reconstructions quite frequently. So we've been able to have that conversation with them, and most of the time, Dr. Marchant and Dr. Curl will send people over for prehab physical therapy anyways. So that gives us a chance to kind of talk to the patient and kind of let them know what's going on. And I think that would be a good time for us to maybe run them through some of the criteria for coping and non-coping. So like running them through a 6-meter hop test if appropriate, giving them the KOS, the global rating scale, figuring out how many episodes of giving away they've had. And if we really think that they could cope with this, maybe speaking to the surgeon at that point. We have had conversations with our surgeons about, and most of them are very much on board with this. I just think that we need to continue to bring it to the forefront because it is very easy to, oh, you tore your ACL, let's get this fixed. Like that seems to be the quick option, not realizing that you're still going to have a 9-month recovery, the possibility for some post-surgical degeneration or arthritis, swelling, and you may not return to prior level of function. So I think we just need to continue to speak to our surgeons and kind of everyone get on the same page as far as what their expectations are, and can maybe we request that all of your isolated ACL tears go through a couple of weeks of PT and then let's decide about surgery at that point. Like I think that really needs to become the norm.
Have you had patients who were hopeful to be copers, but they're so fearful to do anything that maybe surgery is the best option for them to help them with that? Have you encountered that?
I haven't necessarily gotten to the point where I've had to like suggest surgery being the primary option. I just started with one woman in particular now. She has single mom, no option but to wait a year plus to have surgery if she can have it at all. Started a new job, has a toddler, all that kind of stuff. But she is incredibly fearful. It's her second tear. The first one failed. And she is incredibly fearful to do anything, does not want to stand on one leg, doesn't want to necessarily, has a lot of trust issues with the perturbation training. So would an ACL surgery probably be a better option for her physically at this point? Maybe, but life-wise, it's not an option. So, and that's where it kind of goes to your point where we have to take in the bigger picture of the patient instead of just focusing on their left knee that is ACL deficient. So have you encountered anyone that you thought like they thought that they could cope, but you thought otherwise?
I've more so encountered people that are just initially fearful to try anything. But the good thing with PT is that we're seeing these patients for a lengthy period of time and we get to know them and they get more comfortable with what the training that we're doing. And I think that's what ultimately happens. I haven't really seen anyone that was so fearful to do anything that they ultimately had it. I did also have a patient who was a mother who also had kids, and it just timing wise, she had to wait till the summer and she tore it in the fall. So just kind of being as safe as we can to not put her in compromised positions to potentially have a fall and tear her meniscus or something extra, to get her through that period of time because life happens. So
Right. Exactly.
oh,
And that also may be the time where you start to talk to the patient about like protective bracing, just to avoid any further damage. Because life happens. Like we can't control the external factors in everything, and but we also want to help protect our knees and not do early joint replacements on people that maybe we could have done stuff early on to help prevent that. But yeah.
for the adapters, do you find that they kind of come to terms by themselves to be like, maybe I can give these things up, or is that more of a conversation that you're having with them?
I think it's split. I have some people that are like, no, I'm good. Like I don't need to ski. I don't need to play sports. Like I can't go through this again. Like I can't. And a lot of times I think that it's the second time around ACL tears. Like our first time around, everyone's so hopeful. I'm going to go back to everything. And then it happens again. You're like, well, I can't go through this again. Like I'm fine. I'll do without. But then other people, I think they come in and they're like, I need to get back to X, Y, and Z. And then we start to give the education. And going through the ankle fracture recently, I feel like I've gotten so much better at this talk, but I'm like, you are an adult with adult responsibilities. Like you don't get to your parents don't get to take care of you and you get to miss school and people are paying your bills. Like, we have to be realistic here. And if you're not going on to be a professional soccer player, volleyball player, football player, can we find other things that kind of get your endorphins going or that you enjoy doing that don't put your knee at such an increased risk of injury? And I think once people start going through and trying new sports and trying new activities and realizing that, like, and going through the hard work of the 9 months of PT, I think they start to realize, like, there are more things to life than pick up soccer on a Sunday that results in a 9 to 12 month recovery. So I think it's a little split in that regard.
Yeah, the personally having been through a bunch of injuries myself, it's definitely hard to come to terms with, like, all athletes retire at some point, right? So unfortunately for some of that, or for some of us, that timeline comes sooner than we like to admit. But
Yeah, I
yeah,
mean,
really hard.
I'm retired at this point. I think my boyfriend, my parents, my coworkers can all say that if I go back to playing soccer, like, they're gonna disown me. So
Yeah, I
I
hope
get
not.
it.
Yeah. This has been awesome. A lot of great information. Is there anything that we missed or haven't covered, or any main points you really want to get across to any physical therapists or students listening to this about copers, non-copers, and adapters?
I think we hit most everything. I just want to kind of reiterate that education is key to all of this. So have the knowledge as a PT, do the research, really look at your patients. And just because someone comes with an ACL tear, like, look at the bigger picture and don't necessarily assume that surgery is the next best option. Look at the person, look at their strength, look at kind of what surgery would turn out for them in the next 9 months. I have a gentleman now, all he wants to do is hike. So he probably didn't need his ACL reconstructed to go back to hiking. And he's having swelling, joint stiffness, like having a lot of issues. So just look at the bigger picture. And I advise everyone just to take each patient individually and educate them on the different options, but also talk to your surgeons to see what their opinions on it are, and just realizing that an ACL reconstruction is not the end all be all. There's a lot of I guess negative symptoms that can still lag even after surgery for months and years to come. And then the only other thing that I want to harp on just one more time as the return to play program specialist is focus on your criteria for progression and not your timelines. And just make sure that you're progressing your patients enough, um, and you're doing them the best service that they can. If you don't have equipment, get them to a gym that has equipment or get them to a clinic that has equipment, and just recognizing, what their goals are and just be good therapists.
Hearing you talk about that just brought up another point in my head that I've heard many surgeons say, that, like, surgery is not a guarantee. It's not 100% mean that you're going to get back to doing what you love to do. So if we can help patients and athletes return to doing what they love to do, maybe a modified version, then avoiding the OR at all costs is always a great way to go.
Exactly.
We ask all of our guests, what is your favorite quote that drives you, that motivates you?
So I am going to use one that I tell my patients all the time, but I think it's applicable to everybody and all walks of life, really. You don't have to be perfect. Just try and be 1% better today than you were yesterday.
Love it.
So
Awesome, Sam. It's been a great conversation, and thank you for being here.
thank you so much.
I did forget to ask you, where can people find you?
Oh, you can find me at MedStar South Baltimore location. I am in the outpatient building. You can also email me at samantha.j.king@medstar.net. And there should be a bio on the MedStar page that will be updated shortly. Just email me or call the clinic, and I'm here most times.
Awesome. Thanks so much, Sam.
Yep. Thank you.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.